All right, here we are from the HIMSS floor, and go ahead and introduce yourself.
Hi, I'm Khan Siddiqui. I'm the founder, Chief Medical Officer, and Chief Technology Officer at Higi.
So I love grabbing Chief Technology Officers because we can get down into the technology. But before we do that, tell us a little bit about what Higi does.
So Higi is a population health enablement company. We basically enable population health, and the way we do it is through our devices in the community. We have about 10,000 of these devices in the retail pharmacy, community centers, homeless shelters, churches, and different other locations that our customers would want them in. And we basically enable consumers to interact with the data, with this collect structured data through measurements as well as patient-reported outcomes, and then feed into analytics platforms, EHRs, and other clinical workflow applications that as needed. We also provide software solutions to activate patients on the kiosk as well as do gaps in care closures for our population that are at risk, focusing on Medicaid, Medicare Advantage, uninsured populations.
So we can actually talk about two different topics. We can talk about interoperability, because somehow you're getting all that data, which is phenomenal. And then the second is we could talk about the consumerization of healthcare and getting it out there. So let's start with the data silos to start with. So you've been a big part of the interoperability showcase here. The rule just dropped. I'm sure you read all 300 or whatever pages of it.
Absolutely.
So what is the state of interoperability right now? I mean, what are we looking at? Is do you guys use FHIR? Are you bringing it in? I mean, what does it look like?
So we've been proponent of patient owns the data, and we are custodians of the data, and we allow them to move data wherever they need to move with patient consent. Right? That's our philosophy. From day one, we've done that. We've had Open API available for 5 years plus years through our Higi platform, as well as now as FHIR's come out, providing the data in a FHIR resource format also. So there are multiple levels of how I think about interoperability. There's what I call the envelope, how you wrap a content around, and then I call the letter or the content inside that envelope. So everybody's come to this web services based standards to how you move the data around.
Right. So the plumbing's in place.
Plumbing is in place, and we've been using that. That's robust and is having fun.
But still, what are we moving through those?
What
pipes?
is moving through the pipeline is what now all the discussions that are happening. So I think that is what needs to be figured out. I have a philosophy that you need to identify the use cases on what those needs to be and how people actually implement that. It's fine, because if you look at how web standards are done, people have not created structure of the content inside web services, but more on how the protocol is and keeping the data in a structured format. So define the structured format, not the template on how the format should be added, and that's how kind of we've focused on from our side of things.
So, what data do you have access to in your?
Sure. So obviously we collect data through measurements of devices, the blood pressure, weight, BMI, body composition data from our devices. We also collect patient-reported outcomes through validated tools as surveys on the device. Plus we connect to 80 plus wearables, home monitoring devices to bring data into clinical workflows. And then through patient consent, we also pull pharmacy data to select partners who work with us, who need that data into that patient record, and then push back into clinical workflows as needed.
So a health system as an EHR, and they like to deliver it to the clinician in the workflow through the EHR.
Absolutely.
You can push that data back through.
Absolutely. Let me give you an example of Rush Health System in Chicago. So they have two big use cases with us. So they're at risk for hypertension population. So they have a hypertension clinic that they have to deal with, and then they have a homeless population, because being in the west side of Chicago, that they're at risk for. So Shafiq Rabu, who's one of the visionary CIO over there, came up with this idea that instead of dealing with these patients when they show up in the ER, how about we engage them in the homeless shelters? So they actually put Higi stations in homeless shelters in Chicago, where they screen the patients and then do care coordination with they need social services, any kind of other services needed, and then triage them to the right care as needed instead of showing up in the ER. So for example, when we implemented the kiosk in homeless shelters, 9% of those population were in hibernation crisis. A single uncomplicated admission for hypertension crisis is $24,000, single, right? And most of these patients have cardiovascular complications, neuro complications, which goes $50,000 plus per admission. That's a huge cost that's a system. And if you identify those patients earlier on, treat them in an outpatient setting, you reduce all that cost that they would have if they showed up in the ER. So that their incidence in hypertension crisis in homeless shelters has gone from 9% to 1%.
Wow.
Right, so they've been able to show that difference in that by using Higi as a tool device. So not only do that, but they also collect socio-determinant data on the station, so understand what the patient's needs are, and then be able to direct them to the right services through care coordinators at the homeless shelter.
So, especially urban areas, this is a very interesting solution that health systems could look at. Not to do a commercial, but the reason I like it is because it does blend. We're talking a lot about social determinants at this conference. We're talking a lot about consumerism still, and because we're still at the beginning, we're trying to figure out where does it fit and how do we put it out there. And this is a great example of taking medicine to the individual, and then having the individual be the locus of.
If you think about it, right, half of the U.S. population makes $40,000 or less household income, and the cost of that population to care is twice as those who make 100,000 or more, right? Plus the cost is higher on the elderly side of things. Everybody is focusing on building technology for affluent, healthy, right? Extremely
or young and healthy, or acute,
or acutely chronically ill patients, or post-acute, right? Nobody's focusing on what is the preventive monitoring space for the rest of the population, right? You're focusing on the diamond, the pyramid on top, tip of the pyramid, when you're focusing on acute and that population. But year over year, it's that bottom of the pyramid that becomes in the top, right? If you don't address it locally, so how do you do it in a scalable manner? And that's how we do this.
But here's I know we're doing this because we are nonprofit organizations that care for our communities. Yes. But what is the economic engine for putting these kiosks in a homeless shelter? I mean, that's probably one of the questions people are asking. Like, how do you stay in business?
I think so it's really it was Rush's need. Rush is paying for those kiosks that goes in there because they understand their risk on this population when they show up.
Because it's driving up their costs.
Right. I mean, if that patient shows up in the ER, they have to take care of the patient in the ER, right? And the cost of that is say much higher versus taking care of them at the homeless shelter or an outpatient setting. So that's the economic model on them is very clear on how they do it. In hibernation clinics, similarly, right? I mean, you have certain, as an academic medical center in an urban city, they're not designed to be primary care, extensions. The question is, do you build more brick and mortar and extend your primary care, or do you use extension primary care into retail as a way to engage with these patients and continuously monitor them? So in Rush Clinic, when they enroll patient in hypertension programs on Higi, they have a Higi sitting in their in the clinic too to enroll the patients. Patient can go in any of the grocery stores or the pharmacy chains in the city, do their blood pressure monitoring. Data goes back into the Epic EHR, where the care coordinator looks at it, and then based on the data decide what the patient needs to do and can do a telehealth and remote monitoring to deal with it, instead of the patient coming in, taking time off from work, paying for parking, paying copay to see the doctor. You just reduce the entire cost from the patient side of things and from the provider side of things to manage hypertension at scale.
So 2 implementation questions. So do you these kiosks, are they branded Higi or are they branded Rush?
They're branded Higi.
They're
branded Higi, but all the digital aspect of, they can have a lot of Rush messaging that is happening, and Rush will have a tile on the kiosk where the patient can say, I'm a Rush patient and I want to share my data with Rush. And then when they click that button, then what the question they need to answer are personalized and based on what Rush's needs are.
So we have some geek people who are watching the show. So let's assume they want to implement it in LA County. And they're going to put this thing out there. What does an implementation look like for a health system that wants to have their button on there?
First of all, it's very simple. We already have stations deployed in 10,000 plus locations nationwide. So you can just do an API integration and just get consumer to share data, and they don't have to do anything with us.
So it doesn't matter if they're Epic, Cerner, Meditech.
It doesn't make a difference, right? You're just pulling data through as a FHIR resource, and you want to do that stuff. If you want to do more gaps in care closure type of things, then we have a software solution for that stuff. And then what happens is the tile shows up for LA County, for example, on the kiosk, and the patient comes and self-identifies what it is. Whatever the LA County wants to know about the patient from a social determinant point of view, or any other thing that they care about, we can customize those questions to ask them in real time, and the data goes back into either, if they want, into the analytics engines, they want into EHR, or we have our integration in Salesforce Health Cloud that we provide a turnkey solution for care coordinators to look at data.
So there's a new rule. I mean, what's your thoughts on the new rules that just dropped? Do they impact you?
This is exactly what we've been doing for the last 7 years,
right?
It's patient-generated, consented data. So because of philosophy, a patient owns the data, and they give consent to share. I mean, we are really aligned with how they've been thinking about. So, we're partnering with Karen Alliance to really push this idea of patient-centered exchange of data. So when a patient gives consent, and a patient wants data pulled from an EHR, from a claim system, from a payer, all of the hurdles of interoperability go away because patient generating that request. Similarly, patients generating requests to send data, exactly the same way. So I think we are like, there's Apple that is doing it for everybody that can afford devices. We are doing it for anybody that cannot afford devices.
Phenomenal. Hey, thank you very much for taking the time.
Thanks,
Great
Phil.
solution.
Yeah,
Appreciate
thank
it.
you very much.